Afternoon, everybody, and welcome to this session starting the ESH-ISH Congress. We are on a virtual mode, unfortunately, so we cannot see each other. We may wait for a few more time and windows to be able to do that. But I'm very happy anyway that we have this chance to address even virtually an important topic. And this is the importance of nocturnal blood pressure assessment and the clinical relevance of doing that. I will just give you a short introduction, and then I will introduce the other speakers of this important workshop. We are interested in sleep because, of course, this is quantitatively important. We spend 1/3 of our life sleeping, which is not nothing. And we know that during sleep, there is a very complex arrangement of different mechanisms in the central nervous system addressing cardiovascular regulation. And indeed, we need still to understand better why there are some cardiovascular events that preferentially occur at night, and what are the different changes occurring when you have alterations in sleep patterns and in respiration during sleep. That's a typical intra-arterial ambulatory blood pressure profile, and we can clearly see how importantly blood pressure changes when you sleep, either during the night or during the daytime. If you take a nap, there is overall a reduction in blood pressure, but this is also accompanied by a number of other changes. And this is clinically relevant. That's an old study, the SISTIO study, and we had the chance here to have a placebo group in elderly people with isolated systolic hypertension. You find that the events rate over a 2-year follow-up time was only mildly associated with clinic blood pressure. It was better associated with the daytime pressure, the 24-hour, and best with nighttime pressure. And other studies show the same that will be discussed by my colleagues, and this is an important reason for investigating blood pressure at night. Another reason is the dynamics. Usually, as I said before, blood pressure is falling at night. This is called dipping. In some people, this does not occur, the non-dippers, and in others, it may even be reversed. You have a rising at night. There are many issues behind that, among them sleep apnea, but not the only reason. And this may also be clinically important. Again, SISTIO study, after accounting for the average 24-hour pressure, whenever you have an increase in nighttime pressure, you have an increase in events rate. The Oazama study in Japan, same results. The non-dippers, and even so, more evidently, the inverse dippers were characterized by higher risk of events and mortality. So we need to do something. ABPM is certainly giving us a lot of information, but the intermittent inflation of the cuff at night can be a problem. So we have to address a number of important issues, and these are reproducibility of nocturnal levels, reproducibility of nocturnal dipping, and we have some data showing that both are not optimal in many situations. But we also have to consider the possibility of sleep disruption by cuff inflation, and as a consequence, the poor acceptability by patients. Most of them don't like to have a BPM at night frequently performed. In a recent paper, we addressed some of these issues, also looking at the future, given that the modern technology is providing us with new solutions through which we can use home blood pressure monitoring devices to get information at night. Again, here we have to go deeper into this possibility, because having a nocturnal blood pressure measurement through the home BP device may offer us a lower number of readings, but spread over more days. And then we have to consider using a wrist rather than an arm cuff to reduce the interference with sleep. So the pending issues are, in my opinion, what is the difference between wrist and arm blood pressure measurement in this specific situation, the possibility of artifacts due to sleep movements of the arm, and then as a consequence, the possibility of changes in the hydrostatic height difference between the heart level and the wrist level, which may affect the values of blood pressure. Then we have to decide how many measurements can be optimal to predict outcome in a night, and how many nights should we use. So some work to do, but this is important, because if hypertension remains a stealth killer, we may improve the situation through many different actions, including better control, better education, whatever, but also by a more precise assessment of blood pressure, including what happens at night. And this is what we will discuss, addressing the new results of research in our workshop. Professor Sanner will right now show some new data on the possibility to approach nocturnal blood pressure in a different way. Professor Cappuccio will discuss what are the clinical consequences, the risk of events in patients' population related to nocturnal hypertension. And then Professor Schoors will offer us some examples and clinical cases. And then we'll have the chance for some question and answer. You're welcome to pose your question to the chat, and we will respond to them at the end of the session, addressing all the issues you want to raise. So I don't want to waste any more minutes, and I'm very happy to introduce now the first speaker, Professor Sanner from Wuppertal in Germany, who is going to give us a talk on new approach to nocturnal hypertension assessment. Bernd, please.
Dear Gianfranco, thank you very much for the introduction, and good afternoon, ladies and gentlemen. We are all well aware that there are many circadian rhythms in human beings. During the night, there's a gradual decrease, for example, of glomerular filtration rate and diuresis, heart rate decreases, breathing rate decreases, and there's also a gradual decline of systolic and diastolic blood pressure during the night. This is a phenomenon that is organized and determined by clock genes. It's a physiologic mechanism. It's called dipping, and it is linked to the state of sleep. As we have just heard by Gianfranco, you know that the nighttime or the hypertensive values or hypertension by itself is a main risk factor for cardiovascular disease. And the nighttime blood pressures are the best predictive. So you could see in this study that measurement of blood pressure during the night and the absolute blood pressure values at night are much more predictive of cardiovascular events and cardiovascular deaths in the future than daytime blood pressure. And more important, ambulatory measurement of blood pressure is superior to clinic measurement in predicting cardiovascular mortality. So one should take ambulatory blood pressure measurement methods to evaluate nighttime blood pressure. But it's not only the absolute level of the blood pressure at night that is important and predictive of cardiovascular events, it's also the degree of dipping. And compared to dippers or even extreme dippers, those that are non-dippers or risers, meaning that blood pressure even increases during the night, they have a worse prognosis and the cumulative survival rate is lower, as could be shown, for example, in this study. Well, what are factors that can influence blood pressure levels at night? And as you can see in this table, there are many factors that have a short-term or even long-term influence on nocturnal blood pressure values. That's, for example, lifestyle measurements like exercise before going to bed, it's smoking in the evening, the environmental factors. The measurement devices by itself have influence on the absolute values detected at night and the blood pressure values at night because they might disturb sleep. And there are many other clinical factors. And as I've just pointed out, the dipping in blood pressure is linked to the state of sleep. So every disturbance of sleep by itself, or even having no sleep, has a huge impact on nocturnal hypertension and nocturnal blood pressure values, like sleep disturbances, for example, insomnia or obstructive sleep apnea. Furthermore, chronic kidney disease, old age, salt intake, or many other secondary hypertension forms like renal artery stenosis might influence blood pressure values at night. Well, we've just heard that ambulatory blood pressure monitoring is the best suited method to detect nighttime blood pressure. But there are problems and disadvantages of ABPM. It's expensive, it's not always available, it might be uncomfortable, it can cause sleep disturbances, and due to the high night-to-night variability of blood pressure, the reproducibility might be low because if you measure only one single night, this might not be representative. Therefore, it's important to think about home blood pressure monitoring, whether This is better suited to detect the nighttime blood pressure values, and you have to check whether it's also predictive of cardiovascular events. There's one study that I want to show to you. It's the J-Hub Nocturnal Blood Pressure Study, a Japanese study in more than 2,500 patients with a mean age of 63 years, and they all had cardiovascular disease. And they followed for a period for up to 7.1 years in a mean. Well, they all had home blood pressure monitoring at night. And as you can see on this slide and in the figure, there was a strong predictor of incident cardiovascular events like stroke or coronary artery disease events, even after adjustment for the usual covariates and also for office and morning home systolic blood pressure values. So it seems that HBPM is comparable to ABPM in predicting cardiovascular events in the future if you see the nighttime blood pressure values. Well, one disadvantage of measuring blood pressure at night is that the measurement by itself can cause sleep disturbances. And nearly 2/3 of the patient population who have blood pressure measurements at night complain about bad sleep, poor sleep quality. And that's why one should think about wrist cuff devices to evaluate nighttime blood pressure levels. And these are the results of one study where they compared the wrist cuff devices with an arm cuff device with regard to sleep quality. And what could be shown is that measuring nighttime blood pressure values with the arm cuff device is worse, and using the wrist cuff device is less disturbing. Another advantage of HBPM and wrist cuff devices is that it can be used over several nights. And if it does not influence sleep quality, you will have high quality values. So if you see the fact that HBPM might be superior to ABPM and wrist cuff devices are superior to arm cuff devices with regard to sleep quality, it is only consequent that new devices are developed. And I want to introduce a new device, the Omron Night View. This is a wrist-type home blood pressure monitoring device that can measure blood pressure values during the day as a usual HBPM monitor, but also during the night. This device has a 2-layer bladder structure, so the artery is occluded over a longer, with a higher length, so the accuracy is higher than using a conventional cuff. Furthermore, there are 3 nighttime measurements of blood pressure. 2 are fixed. One is at 2 a.m. and the other one is at 4 a.m. And the third one is programmed that it's 4 hours after activation of the nighttime measurement. So if you go to bed at 11 p.m., there will be measurements at 2 and 4 a.m. and an additional measurement at 3 a.m. So you will have 3 nighttime measurements. Well, this device has been validated according to international validation protocols, as well in the sitting position, what you need during the day, as in the supine position, what you need during the night. And it's validated with the palms sideways, upwards, and downwards. And it has a good reproducibility. So these are validated devices. But you might have problems, and that's not validated, if the arm position at night is wrong. So if you have the palm on the chest, or if you're sleeping in a lateral decubitus position with the arm below your body. But that could also happen with regular upper cuff, arm cuff devices if you lie on the side and lie on the side where you measure the blood pressure. So these are the same problems. Another point that you should think of is that you have just 3 measurements during the night. You can measure as often as you like during the day, but there are just 3 measurements during the night at 2 and 4 a.m. and a third one 4 hours after going to bed and activating the mechanism. And this is in contrast to 17 measurements with a conventional ABPM. That's usually between, the nighttime period is usually between 10 p.m. and 6 a.m. And if you measure every 30 minutes, you will have 17 measurements. But I will give you one example of what it could look like. This is the ABPM profile of a patient with a daytime and nighttime hypertension, and you can see that he is a non-dipper. And he measured 17 times at night. And I can show you the results that you could get with the new device, the night watch. And the patient measured 6 times during the day, and it was activated 3 times during the night. And you can see that the pattern is obviously the same. And another advantage of the wrist type device is that it's easy for the patient to use. You can use it in your home setting every day and every night and several nights in a row. And so you can get much more information about the actual blood pressure situation. So this is not a disadvantage that you have only 3 measurements at night. It will be good for the patient because sleep quality is not as much impaired. And I want to summarize. First, nighttime blood pressure is the most potent predictor of outcome. Second, home blood pressure measurement and ambulatory blood pressure measurement are similarly associated with indices of target organ damage. And third, wrist devices are better tolerated and can be used over a longer period of time than conventional ABPM and are therefore a new option to measure nocturnal blood pressure at home. So thank you very much.
Thank you, Bernd, for this excellent talk. You have been clearly highlighting these new possibilities, and I'm sure we'll have some discussion on them because there are so many issues that need to be addressed and clarified. Now, I'm very happy to introduce the second speaker, Professor Franco Cappuccio from Coventry, United Kingdom. And Professor Cappuccio will give a talk on the patient's population at risk for cardiac events related to nocturnal hypertension. Francesco, please.
Thank you, Gianfranco. Ladies and gentlemen, thanks to organizers for inviting me to address the issue about patient population at risk for cardiac events in relation to nocturnal hypertension. Well, very briefly, in the next 10 minutes, I'll touch few topics. Some will overlap with what Professor Stanner has mentioned. The first question is, should we measure blood pressure during sleep at all? And we'll give you some basic considerations on the circadian rhythm of blood pressure and its basic regulatory factors. The next point I will address is, how does nocturnal blood pressure behave, with some basic definitions of patterns of night blood pressure. And is nocturnal blood pressure important at all? And mainly looking at the cardiovascular risk prediction of these measures. And finally, who is most at risk of nocturnal hypertension? And I will focus on common comorbidities associated with nocturnal hypertension. The control of our sleep-wake cycle is situated in the suprachiasmatic nucleus of our hypothalamus. It is made of a small group of highly specialized cells, we see here, I think, identified as a circadian pacemaker, or sometimes called the body clock. Sorry, I'm passing the next one. These little cells control the timing of most 24-hour behavioral and physiological rhythms, which will include the sleep-wake cycle, including alertness, performance, hormone production, temperature regulation, metabolism, and of course, blood pressure. The biological clocks have the ability to oscillate in a self-sustained manner and to sustain the biological rhythms throughout some output pathways from the SCN down to the periphery. But in addition to the central body clock, sometimes this is referred to as a master clock, there are several peripheral clocks, sometimes referred to as the slave clocks. And these are situated in organs, tissues, and cells. And these clocks are, in general, synchronized to the solar day through some input pathways. The synchronization to the light-dark cycle is through some direct neuronal projection from the retina to the SCN. The day-night rhythm is present in every function of the body, particularly as a result of the connection between the central clock and the peripheral clocks. And this slide illustrates the complexity of the circadian regulation in every system's organs and tissues. And in particular, circadian variation in blood pressure values exist and have highlighted with the two boxes either side of this circle. Blood pressure varies from day to night, with a peak in late afternoon, early evening, and a sharp rise in the early hours of the morning. Several mechanisms are involved in blood pressure regulation throughout day and night, and they are the sympathetic and parasympathetic nervous system, hormones like melatonin, vasopressin, acetylcholine, the adrenocortic hormones, and obviously cortisol, but also metabolic hormones like insulin, ghrelin, adenopectin, leptin, and part of the renin-angiotensin-aldosterone system. So you can see the complexity of the involvement and the relevance already to the cardiometabolic regulation. One important concept is the desynchrony or misalignment. Now, when there is a desynchrony and misalignment between the biological clock and the circadian rhythms, and this is very often seen in shift workers, for instance, or in some so-called non-24-hour disorders, if sustained, this desynchrony leads to a variety of health outcomes. The biological consequences can be either immediate or could be long-term and would involve neurobehavioral mechanisms like reduced alertness, impaired cognition, lower mood, but also physiological mechanisms like high blood pressure, glucose intolerance leading to insulin resistance, associated with weight gain, and also reduced immune response. And the long-term morbidity and mortality consequences are very often detected in epidemiological studies with a particular reference to chronic diseases. So we said blood pressure variation over 24 hours, we said follows a pattern with a peak in the early morning that we call a morning surge, and the decrease at night, as already been referred, is the dipping. The morning surge is caused by a variety of mechanisms, as indicated in this pink box on the right-hand side. The nocturnal dipping, which is usually considered more than 10% of the daytime blood pressure, could be in some cases extreme, in excess of 20% of daytime blood pressure, or, as we have heard already, could be blunted so that we have the condition of non-dipping. Or in some circumstances, you can even have a rise in blood pressure at night. And that would be to a variety of mechanisms indicated by the blue box on the left-hand side. In some circumstances, and that is the red box in the middle of the night, we can experience and detect nocturnal surges. Now, these variations are the results of two components. One is the endogenous circadian rhythm, which exerts its peak in the evening hours, and the behavioral effects that are superimposed on the circadian rhythm. So the blood pressure starts declining from late evening onwards, reaches a nadir around midnight, and rises just after awakening in the morning. Now, as already mentioned, prospective follow-up studies show very clearly that the best predictor of future cardiovascular events is the average nocturnal blood pressure, once all the readings coming from 24-hour blood pressure monitoring are taken into account. And this is true for both systolic and diastolic pressures. And the recent position of European Society of Hypertension acknowledges very clearly that there is compelling evidence that nocturnal blood pressure is superior in terms of predictive power to causal of its blood pressure once we talk about predicting of all the cardiovascular outcomes, the total, the MI, the strokes, and the others. An increase in nighttime blood pressure may indicate the occurrence of a number of associated pathological conditions. But let's see what they are. Before getting into that, we talk about nocturnal hypertension, but it would be good to define what we mean by nocturnal hypertension. That's at the moment in clinical guidelines until very recently, more emphasis in terms of definition of hypertension thresholds or definition of blood pressure targets for treatment always refer to daytime blood pressure. Well, the definition given by the latest European guidelines defines nocturnal hypertension and as a mean, a sleep systolic blood pressure equal or greater than 120 millimeters of mercury, and or a mean a sleep diastolic blood pressure equal or greater than 70 millimeters of mercury when measured by 24-hour ambulatory blood pressure monitoring. There are other aspects of these definitions, but one important one that we also have a definition of isolated nocturnal hypertension, and that is a blood pressure at night above those settings with a daytime blood pressure which is below 135/85. In other words, we have a normal daytime blood pressure but only raised nocturnal hypertension. It's important also to acknowledge and to know, to be aware that at the same time American guidelines have been published alongside of the Europeans, in which many things differ. In particular, according to the threshold definitions and targets, also the nocturnal hypertension is defined with a lower threshold of 110/65. The mechanisms supporting the rising blood pressure at night are multiple. Increased venous return to the heart due to the supine position, with reduced heart rate and an increase in intravascular volume due to increased interstitial fluids reabsorption from the lower body, will lead to an increase in a nocturnal intravascular volume. The increased nocturnal intravascular volume will result in nocturnal rise in blood pressure. High left ventricular preload and left ventricular wall stress will develop. Sodium retention will occur, all representing powerful long-term risk factors for subsequent cardiovascular disease. Furthermore, nocturnal hypertension will trigger glomerular hyperfiltration, representing an early signs of renal deterioration and a risk of chronic kidney disease. Let's review some common conditions associated with nocturnal hypertension and some of the associated possible mechanisms. Patients with nocturnal hypertension are characterized by older age or presence of diabetes, higher levels of serum creatinine, high calcium, sometimes uric acid, than nocturnal non-hypertensive patients. These conditions involve several organs and systems. You can see, I've just listed some here: respiratory conditions, cardiometabolic conditions, renal conditions, as well as behavioral systems. I'm just touching on sleep systems like insomnia or nutrition system as a high salt intake. The mechanisms likely to contribute to a rise in blood pressure at night in these conditions, as well as in the condition I listed below, in addition to these, could be related to activation of the sympathetic nervous system. And sometimes we explain the symptoms associated with nocturnal hypertension, like nocturia, or sometimes increase in heart rate. Disturbed baroreflex sensitivity, sleep disturbances, definitely we mentioned insomnia or reduced sleep quality. We're using a BPM, but any kind of arousals, fragmentation, snoring, or even as I list below, periodic limb movement by disturbing sleep can lead to a rise in blood pressure at night. We mentioned salt sensitivity, very common type 2 diabetes, which could be a component which would lead to a contribution to a rise in blood pressure, fluid retention, and also polyuria nocturia associated with SNS definition, could fragment and disturb sleep as well. Imagine just waking a few times a night to go to the toilet. But there are also some subtle, less visible mechanisms which have been demonstrated, like endothelial dysfunction developing, inflammation, arterial stiffness, and more are related to the presence of nocturnal hypertension. And as Professor Sanne referred to, it's very difficult at this point in time of our knowledge to dissect out how many of these factors could be a causative component of nocturnal hypertension, from how many of these could be the expression of a disturbed sleep leading to these alterations. One of the commonest conditions associated with high nocturnal blood pressure is a sleep apnea syndrome. I want to devote just a bit more time on this, as grossly undetected until recently, now becoming more important in the knowledge of people looking after hypertensive patients. It's a chronic condition frequently associated with hypertension and high nocturnal blood pressure. It's a sleep disorder which is characterized by frequent episodes of partial or complete collapse on the upper airways during sleep. These obstructions cause cessations of airflow, disturbance in gas exchange with hypoxia, and frequent arousals and often snoring. During these episodes, the patient experiences recurrent cycles of oxygen desaturation, sympathetic overactivity, and metabolic effects. Recurrent cycles of oxygen desaturation cause sleep fragmentation, restless sleep and frequent arousals, fatigue, excessive daytime sleepiness, and all the symptoms associated with acute problems of attentional failure, tiredness and fatigue, and sometimes with excessive daytime sleepiness, the commonest cause of road traffic accidents. At the same time, sleep apnea syndrome activates a variety of mechanisms like sympathetic overactivity, metabolic effects, as I said, endothelial dysfunction and inflammation, causing high nocturnal blood pressure. Non-dipping is very common, or even the reverse dipping is common. We've got nocturia, night sweats, glucose intolerance, and in the long term, the development of insulin resistance and diabetes. And in the long term, it's not adequately controlled. Obstructive sleep apnea is one of the strongest predictors of cardiovascular events, both related to arrhythmias, sudden death, myocardial infarction, stroke, and heart failure. There is a strong and graded relationship between the presence and severity of sleep apnea and the occurrence of these new cases of hypertension. As you see on the left-hand side here in the prospective study, the presence and severity of sleep apnea as measured by the apnea-hypopnea index, which is the average number of apneas per hour, shows a graded relationship from mild to severe hypertension in the risk of incidence of new cases of hypertension. And likewise, sleep apnea syndrome is a strong and graded predictor of risk of death in general and cardiovascular death in particular. So to conclude, blood pressure follows a circadian pattern. Nocturnal blood pressure is a strong predictor of cardiovascular morbidity and mortality, and stronger than daytime blood pressure. High nocturnal blood pressure is common in several conditions, and it may be an important prognostic and therapeutic. It must have therapeutic implications of this. Nocturnal hypertension is common in sleep apnea syndrome, type 2 diabetes, and many other chronic conditions, which are very common now in patients with hypertension, and also with behavioral factors, including nutritional and sleep disturbances. Thank you.
Thank you, Francesco. A very important topic. Again, we will discuss it later for sure. And now I was told that Professor Schoors is going to participate in a different way, which means through a video. And then I will ask the technicians to show this video so we can go then to the question and answer session to end our session. Please.
I will focus on the nocturnal blood pressure measurements, and I will focus on a new device made by a company of Omron, which is a wrist device, and I will guide you to this results I had with some patients. Now, for the nocturnal blood pressure measurements, we normally use the 24-hour blood pressure ambulatory classic machine. We all know this machine. It measures blood pressures during the day every 15 minutes and measures it during the night every 20 or every 30 minutes. The advantage of this classic ambulatory blood pressure device is that it's a validated technique. It gives you a bulk of data. We have a lot of data because we have measurements every 15 minutes during the day and every 30 minutes during the night. So it gives us at a whole, after 24 hours, about 60 to 80 measurements for the whole day. And the advantage is that you have measurements during day and night. Now, every device has an advantage and also has a disadvantage. Now, what I hear of my patients, which is a disadvantage, is that it measures your blood pressure every 50 minutes, which is quite a lot and can be disturbing for the patient. Now, some patients complain about measurements during the day, but a lot of patients complain about the measurements during the night, giving them sleep disturbance, either due to the fact that it measures your blood pressure every 30 minutes and also by the noise of the device. A further disadvantage is that it measures your blood pressure only for 1 day. You can keep the machine for 2 days, but mostly we do it for 1 day. And this is then the data of only 1 day. Now, I'm a cardiologist. I also look at heart rate, and I know that the use of a Holter registration for heart rate for 1 day doesn't give you all data of the patient because not every rhythm disturbance you will see on 1 day. Now we will look at this newer device. So this is the small Omron device put on the wrist of the patient. It's a small device, and you can measure with this device yourself during the day. So you push on a button, and it measures your blood pressure like a home blood pressure registration. During the night, you can push on the night button, and then this device will automated gives you 3 readings. It is the first reading 2 hours when you go to sleep. At 2 o'clock in the night, it says 4 o'clock in the night, and it gives a third reading 4 hours after you pushed the night button. So you will have 3 automated night readings. The possible advantage of this device is that you can give the device to the patient for 1 day, but you can also give this device to the patient for 1 week. So you will have several readings for more than 1 day. And the possible advantage of this device is that it will give less disturbances during the night because it doesn't make any noise, and the measurement is quite non-disturbing. That should be the advantage of this device. Now, this is what the company says, so we tested it. So I did a trial at my hospital looking at the feasibility of this device in several patients, and I used patients with and without a history of hypertension. I gave them the device for 1 week to do measurements for 1 week, and I asked them to put on the device every evening, so to measure blood pressure during the night, 3 times during the night, like I told you, at 2 a.m., 4 a.m., and 4 hours after they went to sleep. And they could also measure blood pressure during the day, but they have to do it themselves. And I asked them to do it between 3 to 5 times during the day. I included in this study, in total, 38 patients. Most of them were male, so 22 males, 16 females. And the mean age of these patients was around 62 years old. Of these 38 patients, about 20 of them had a known diagnosis of hypertension. They were not all treated with antihypertensive drugs. 18 of them were treated with antihypertensive drug. 29 of them had a family history of hypertension. And a lot of these patients already had a blood pressure device at home to do blood pressure home registration. It's about 30 of these 38 patients. Now, in the previous talk, you heard that there is a relationship between nocturnal hypertension and also sleep apnea. So we asked the patients, these 38 patients, if they had a known diagnosis of sleep apnea. And there were just a few, 4 of them, who had a known diagnosis of sleep apnea and were treated by this, all by night CPAP. So the very few of the patients had a known history of sleep apnea. I will not focus this time on the blood pressure data with this night view device, but ask the patient to wear the device for 1 week. They don't need all use the device for 1 week. Some of them had it only for a few days, and the patient who took it the longest was 10 days. So there were data which have between 4 and 10 days. The mean time they used it was 6.6 days. And we had lots of amounts of data. Most of the time it was around 40 to 50 values we had in these 6 days. Most of the data come from daytime measurements because the patient pushed on the button between 3 to 4 times a day. And we also had about 3 night data. This for 1 week. We can later on focus on the data of this device. Now, I correlated with the blood pressure you measure during the day, and there's a clear correlation between this device and the measurements you do yourself. There's also a clear relation between these data and the home blood pressure registration. And I also correlated in some patients with a classic 24-hour device, and there is a clear correlation between these data and the one with the classic 24-hour device. On this talk, I will mainly focus on the feasibility and the easy in use of this device. So I asked the patients after they wore the device for 1 week to fill in a questionnaire. And in this questionnaire, I asked them about their experience with the device and to grade the experience from 1 to 5. 1 meaning it's a shitty device, 5, it's a very good device. And I asked them about comfort of sleep, comfort during the sleep. Another question was about comfort during the daytime measurements. And the third question about the easy in use of the device. All patients, all 32, rated these all 3 questions, so the comfort during the sleep, the comfort during the daytime measurements, and the easy in use, all graded them between 4 and 5. So all graded the device as an easy in use, very comfortable device. Also, one question was, did you woke up during the night due to this night view device? Only 1 of the 38 patients said he woke up during the night due to the device when he used the device for 1 week. More patients said that they had the impression that the device did not work properly during the night because they didn't feel anything at all. But when I then later on confronted them with the results, the device clearly had worked 3 times during the night, but the patient didn't feel anything of the device. No, they didn't feel the measurement of the blood pressure at all. So they didn't woke up at all. And some of the patients really said, I think the device didn't work at all. So it was very comfortable to sleep. So about this device, I think we can conclude that from these 38 patients, this Omron night view device is easy in use. It's like a classic home blood pressure registration. it's well tolerated during the night, which is very important because certainly I have some patients who had this device and used the classic 24-hour blood pressure registration, which was certainly in most of these patients not well tolerated because they woke up a lot during the night. And if you wake up a lot during the night, you can have some doubts about the night measurements, if they're really sleep measurements. And telling this, most of my patients said this device was better tolerated than the classic 24-hour ambulatory blood measure device.
Thank you. Now we have you're running a bit late, but we have time for a few question and answer. I've got some from the chat, and well, one I can reply quickly is, what is the best time for home blood pressure measurement? As you all know from guidelines, the available guidelines, we are recommending in the morning, in the evening, before meals and before taking pills, but now we may also suggest in the night, and this will be confirmed in future studies. Another question for Sanner. Nocturnal home blood pressure might improve the reproducibility of mast hypertension and white-coat hypertension diagnosis. We know that using ABPM and office combined, the reproducibility is not very good. What do you think, Bernd?
I think this is a very important issue because mast hypertension is really important. It has a high cardiovascular morbidity and mortality, and we have to look for mast hypertension, screen patients for mast hypertension if we see, for example, that they have left ventricular hypertrophy, and we have regular blood pressure values in the office. So home HBPM is very important to detect mast hypertension, and especially the nighttime measurements. So I think, yes, this is really important.
Thank you. Is another question from Francesco now. Morning blood pressure surge. There is a different prognostic value in those being risers in the night or extreme dippers. In other words, what is the link between the nocturnal fall and the morning surge? Francesco, that's an interesting question indeed.
In terms of the relationship, it's very difficult to establish. We still don't know much about the relationship between all these episodes. The role of the very early surges, rises in blood pressure, have been known for quite some time, particularly in the consequences they might have. Very early studies have shown, remember in the 70s, that most of, a large proportion of the vascular events, in particular strokes and myocardial infarctions, do happen in the early hours of the morning. And for many years, we haven't had an answer to that. Now, clearly it's shown that the morning surges in blood pressure, for whatever reason they occur, we still have to study, do facilitate in a patient at risk, for instance, fissuration and rupture of plaques, which is then can explain why these events are more common out of the totality. So I think it is important to appreciate all these changes in blood pressure at every time, particularly unexpected surges, do represent an additional risk. So how to handle those, the very early morning surges, is very difficult to answer. One aspect is well known, that these morning surges are very common in alcohol withdrawal syndromes. For very alcohol users, the so-called after night effect of the withdrawal syndrome are very often associated with immediate surges in blood pressure the day after a big binge, and these can trigger stroke, and this epidemiology is very well established. And I think we have to link all these information together in the months and years to come.
Thank you, Francesco. In this regard, I have a question myself for both of you. We know that the risk of events related to morning surge often starts in the pre-awakening period, which means the last part of the night when REM sleep is more frequent. Would it be important then maybe to plan this new device, the nocturnal home BP, to take some measurement also in the very last part of the night and not only now up to 4 a.m.? What's your opinion?
I think that would be a good approach. So, because this is a really risky time. So, another important question that I'd like to ask to you, Francesco, is what do you think? Is a nighttime blood pressure guided approach, does it exceed conventional management alone? So how do you consider the treatment with regard to the nighttime blood pressure values?
Yeah, this is a highly controversial, in this time, particularly in the presence of, at the moment, the only published intervention trials on outcomes that we have, the ESH-ISH trial, which has raised a lot of concerns and debates, and more recently have been rehabilitated in the journal as correct. I think there are many things to answer. This trial shows clearly that if you give blood pressure tablets at night in a randomized trial, the greater blood pressure lowering effect at night is associated with a 50% reduction in risk, in addition to the risk that is prevented by treating daytime blood pressure. That's very surprising given the small difference in blood pressure. Nevertheless, there is another one in the pipeline coming up, the TIME study, which is ready to produce some results soon. It's very logical that lowering blood pressure at night, if that is a predictor risk, should lead to an additional reduction. The problem at the moment is that most of the effects we see on blood pressure in these trials are obviously related to the length of action of the drug we use. And the question is, do we leave uncovered some daytime blood pressure, particularly in the daytime hypertensives who are also nocturnal hypertensives? And this really is not addressed by the trial. The only trial, in fact, by the nature of the trial, has selected out patients who have changed their tablets throughout the trial. So if you see the ESH-ISH trial at the end, the only drug that is kept in a randomized balance is the ARBs. They stop the diuretics because they get up at night. So there are fewer diuretics, there are fewer beta blockers, there are more CCBs. So are those differences due to the type of tablets? Are those differences due to the blood pressure difference? Hard to say, but I think in the future, I think the role of treating nocturnal blood pressure in some way will be vital. Yeah, because the risk is there. How to do it is still an open question in my view. That's my personal view on the interpretation of very limited evidence at the moment.
That's an important point, Francesco, indeed, to address again in the future. We have limited time available. Bernd, very quick answer. There are two questions related one to the other. The question are, if you're using a wrist cuff device, how comparable is the radial blood pressure with the brachial one? And question number two, we are always recommending to keep the cuff at the heart level. How can we do this with the wrist cuff device?
Very important questions. Well, there are validation studies that compared the accuracy of wrist cuff devices compared to regular blood pressure measurement with arm cuff devices. And for the device that I showed to you, the Night View, there's a good reproducibility, and so it's validated and can be used. But the problems might be that during the night you can change the position of the arm, and that might change the results. But this needs to be studied in further studies, because but we also know that you could have the same problem with upper arm cuff devices. So.
Thank you very much. I think we should almost close the session. Just two brief questions I just want to mention. One is on the importance of beat-by-beat recording with the finger cuff at night. Well, I would say that's important, not common and not easy to be used in daily practice, because you may pick up variability beat by beat and pick up very short events, but this is something more for research at the moment. Mm-hmm. The other question was on the predicting power of home and ambulatory blood pressure. We have a head-to-head comparison. As you know, we do not have many studies. We don't have any regarding nocturnal blood pressure at the moment, but that's a very important study to perform for the future. So I wish to thank all the speakers for their excellent lectures, and to thank also Omar for supporting this session, and also, why not, for giving us a new device to measure blood pressure at night. And I wish you a very successful Congress in the remaining days. Wish you a very nice afternoon.